A very, very good evening. So good to see all of you. Welcome to Workplace at the River. You know, time flies, right? We're at the end of February, and I'm sure you have been so blessed, right, for the whole month of February. But exciting things are in store for you for the month of March. And do you know there's a wonderful celebration next week? Because we're going to celebrate our fifth anniversary. Woohoo! Awesome, yeah. So make sure that you registered early and do come, yeah. We look forward to see all of you and partake in this wonderful and awesome celebration and remembering God's goodness in Workplace at the River. But most importantly, today, we can't wait to hear our speaker talk, right? Because we have our distinguished guest today, none other than our Dr. Chong Su Lin, all right? Whoa, wonderful. You know, she's a distinguished, what do you call that? She's so distinguished. She's well known in the medical sector. And currently, she's the Honorary Secretary of the Anglican Diocese of West Malaysia. She's also the Independent Non-Executive Board Director for AIA, Sanglit Medical Center, ECRI, which is a non-profit organization to look into the safety and quality of healthcare, Narudi Management Consultant Healthcare, and she also holds a long list of prior corporate roles, which I'm going to read this out to you because I don't want to miss anything, all right? She has been a management consultant in Pharmacoeconomics, Cambridge, UK, management roles in Subang Jaya Medical Center, International Medical University, project manager for the renovation and construction of IMU campus in Bukit Jalil and Seremban. She was also the CEO of Sunway Medical Center, CEO Prince Court Medical Center, Executive Director Beacon International Specialist Center. She was also the CEO of IMU Healthcare and project lead for the construction of IMU Hospital. She was the lab leader for healthcare in the National Key Economic Area Project with Pemandu, PM's office. She was also the member of the Healthcare Work Culture Improvement Task Force appointed by the Minister of Health. And her qualifications is a wow factor too. Her qualification includes MBBS, Royal Free Hospital School at Medicine, University of London, MBA, London Business School, University of London, Diploma in Biblical Theology, Moore Theological College, Australia. But more importantly, Su Lin is a head keeper of her domestic zoo. 2 dogs, 3 cats, 2 parrots, all right, 2 lovebirds, 1 canary, 1 cockatiel, and a wild musang, all right, that roams around her backyard. So without further ado, let's put our hands together and give her a warm welcome. Over to you, Dr. Chong.
Hi, good evening. Thank you. Thank you for this invitation. Thank you for this place. It's really interesting. So I've got a very schizophrenic background. So I will not be speaking about from a particular perspective. So my parents were civil servants. That actually drives a lot of how I think about healthcare. I grew up in the Methodist Church and now with the Anglican Church. So I'm also a doctor and I used to practice in the UK in those days when junior doctors worked. There was no limit to the number of hours we worked. In that time in the NHS in the UK, there was a lot of rationing. Now do remember that if you were a 60-year-old guy, and we were seeing a lot of people come in from the war times when cigarettes were free, or almost free, given out now. And so 60-year-olds would come in very regularly with a heart attack, into ER. And all we used to do was give them morphine or pethidine and treat them very conservatively. That was it. Then you sent home. And that was the end of care. So that was in the mid to late 80s. And so now you look at Malaysia and you look at the big hoo-ha that has been happening around the insurance sector, etc. And you realize that the same 60-year-old, I'm now about to turn 65, we're considered quite young already, right? Yeah, we are young, right? And so at this age, you expect me, if I turned up in ER with heart symptoms, to be given 100% intervention. And actually, if you look at the clinical practice guidelines, the door to needle should be 90 minutes. That means I should be fast-tracked to ER, through the red zone, and into the cardiac lab, and the needle is the anti-clotting agent. Yeah, and then an angiogram and a stent or whatever. So if you see the difference in how we now look at health. So let's look at Malaysia, because this is not a topic that we can cover really in a day. If we look at the next slide, who provides healthcare within Malaysia? But first of all, healthcare is a human right. So if you look at the WHO, we have a right to a particular standard of healthcare. And one of the things that I want you to be looking at says universal health coverage, the last line, is grounded in primary healthcare. And it's something that we tend to forget. And remind me, we'll come back to that. So healthcare is a human right. Let's look at Malaysia, okay? Who provides care? So the next slide should show you that actually we do have universal healthcare. In the 60s and 70s, Malaysia was seen as a huge example to the rest of the world. We were held as a very good example because we provide universal healthcare. If you look at where that care is being provided, so you've got the Clinic Kesihatan for primary care, but in the community you've got the Clinic Bidan and the Clinic Desa for maternity care and pediatric care, especially those under 2. And then you've got the hospitals, and then you've got the specialist hospitals like Selayang that does endocrine surgery. IJN, the Institute Jantung Negara, was something that was quite phenomenal in that time. It was during Mahathir's time, and he asked my father to go around the world and find out how cardiac health was being done. And that's why we had an Institute Jantung Negara, which unfortunately is now sitting under the Ministry of Finance because it got corporatized. I don't actually quite know what happened there, but it means, let's just digress, it means that if I'm a junior doctor who wants to specialize in cardiology, I can't just ask to transfer to IJN. I have to resign from the Ministry of Health and apply to the Ministry of Finance and go to IJN. So that just gives you some idea that our ministries don't quite talk to each other, unfortunately. Ministry of Health also has to do community health and public health. You know, the tak nak, don't smoke, which failed miserably. Yeah, just never took off. You know, we get a lot of smuggled cigarettes. We've got a very porous border with Thailand, so cigarettes can be gotten very cheaply in the little shops. So public health, and then Ministry of Health also has to do research with the National Institutes of Health, which have now got a very nice building out in Setia Alam. Then you've got the Ministry of Education that runs the education, the university hospitals, HUKM, UMMC, and then you've got some small military hospitals, you know, run under the Ministry of Defense. But basically, the Kementerian Kesihatan really provides all the care for Malaysia. And so, as you know, if you've been to a KKM or GH, hardly any money changes hands, right? 5 ringgit, and then you get 3 months worth of medications. I think we've got somebody from the pharmaceutical industry. 5 ringgit will not cover even 1/10 of the cost of those drugs. And what's happened in the past is that not really invested in our facilities. So if you look at the average hospital, we look at HKL, it's the single largest hospital probably in the world, apart from China. Over 1,000 beds, right? All spread out all over the place. If you look at, I recently visited Penang and the hospital in Seremban, and you look at it, it's busy. It's busy, busy, busy. There's not space, there's no Wi-Fi. And in Seremban, I was running around with my phone, trying to get. You have to be really skinny to work in ER, because it's really cramped. It's really, really cramped. You look up, to my horror, I looked up, first I visited Penang. Okay, so this was a task force during Kyrie's time as the Minister of Health. We were investigating the causes of suicides of junior doctors. So we went to visit the hospital. In Penang, you come out of the lifts, and the first thing you see is a stack of medical equipment, beds, wheelchairs, you name it. It's all stacked there. Some waiting for repair and some waiting to be junked, just there. So when I went to Seremban Hospital, I didn't see the same thing. But I walked outside and I looked back at the hospital, and lo and behold, on all the balconies outside every ward, medical equipment stacked there again. So you wonder, therefore, what's happening with our Ministry of Health hospitals, and they're so busy but so underinvested. Yeah. So in the last budget, they've actually increased the investment. So where does this money come from? It comes from most of us, right? We pay income tax, right? And we've traditionally only ever spent about 4.5% of our GDP. And we've been pushing and pushing and pushing for at least 7 to 8% so that you can actually invest further. But we ain't got the money. We just haven't got the money. Has gone to education. A lot of it has gone to education, and then to defense, and then healthcare. So now finally we're investing a little bit more. But last year, 2023, if you remember, Parliament gazetted this healthcare reform. So I came home from the UK in 1995, and from 1996 onwards, we've engaged one consultant after the other to look at our healthcare, to look at how to make our healthcare equitable. I mean, a fair service to everybody, but at an affordable rate. And I think what you realize is that we don't work with each other. As I said, IJN doesn't work with Ministry of Health. So Ministry of Health decided to do its own cardiac centers in Serdang, etc. So your central IJN, which does a huge amount of very good work, doesn't quite partner with the other hospitals. The clinic Kesehatan are very full, overworked. And in the NKA, so the NKA, when I actually realized that it was in 2010 that we looked at the economic transformation program that Pemandu was running, and healthcare was one of the key areas. And one of the things we said was the public-private partnership. And one of the pilots was the waiting list for CT and MRI in the public sector can be months. And then, and then you get your CT scan, but then there's no one to report because there's just too much volume. So Siemens Healthcare at that time had said, we will come in and we will put in the technology. Why don't we do a pilot, HKL with University Hospital? And HKL would send their patients to the University Hospital to have the x-rays done or the CTs done, and the University Hospital radiologist will report and send the thing back. How many doctors here? So what happened was the doctors didn't want to talk to each other. It was a bit of a blame game. They said, you send us the patient, but you never write anything in the referral note. Like that lah. So we cleared that. Then we had to clear the Wi-Fi, the interconnectivity, because CT scans, a lot of images will take us a lot of memory. Sorted that all out. We were ready to rock and roll. And then Ministry of Health said, sorry, we don't have the money. Don't have the money to pay University Hospital for those scans, and we don't have the money to pay the radiologists to report. And that was it. End of project. And I've not seen anything happen since then, which is really very sad. So the public-private partnerships that we talked about didn't come in. So if you're as old as I am, I came back, and my first posting was in SJMC, and it was headed by an American, Mac Banner. It was HCA that was the management company. So they brought in US practices, and that is the single reason why we have this fee for service. So SJMC at that time was really only for the ones with deep pockets. It was cash-paying patients, people who could afford it. And then as it got popular, the insurance company said, oh, this looks like a good model. Let's then create a product around the hospital service. And that's where the insurers came in, right? And then over the years, you find that you now feel that it's my right to have insurance. You take it for granted, right? Because previously, it was only as a benefit, a corporate benefit for staff. And then it became more widespread. So now, we're jumping up and down because you say, hey, why suddenly so expensive? Single reason, someone like me, I used my insurance to do my cervical spine. Yeah? So I had 4 discs that needed to be replaced. Because of that, I will no longer be covered after 70 because of that one major insurance. Okay? If I hadn't used any of that, I could continue. But so the insurance is risk rated. I'm now considered a risk. Yeah, particularly because I've also had abdominal surgery for cysts. I've claimed against my insurance. So I'm a risk. So therefore at 70, the insurers, if they cover me, they will exclude all these things, right? And so one of the things that we discussed many times in all those years of consultation is, should we have a social insurance like Korea does? That means it's pooled, it's community rated rather than single risk, right? You cover everybody, yeah, so that it's cheaper as well. Because at the moment it's individually covered, right? So when you've used it, your premiums go up. The other thing about it is that insurance is a financial company, so it's under Bank Negara. Healthcare is under Ministry of Health or Ministry of Education. And Chua Jui-ming's time, he tried to get the Ministry of Health to actually oversee the insurance. And then war lah, usual. Then it tak jadi lor. So that opportunity to get it. So now Ministry of Health says, I don't have any jurisdiction over the insurer. I can't tell them what to do. I can only tell the doctors what to do. Then you say, okay, we've got the fee schedule for doctors, but what about hospitals? Yes, we tried to do that as well. We tried to say, you mustn't charge so much for your drugs. Okay, so Sue knows this, right? In a hospital, the single largest margin is made on drugs. It's an open secret. Inpatient particularly, you charge more for the same drug. Why? Because outpatient, if I give you, it's easy for you to go and compare. You go to Caring Pharmacy and say, hey, one Panadol there is only 20 cents. How come you're charging me 2 ringgit? But when you are in an inpatient, how many of you look at your detailed bill, right? And how much each line item, how much the Panadol is. Yeah. So why do hospitals need to charge so much? Because it's very expensive. So your next page, you've got labor costs. So 30%, maybe 30 cents in every dollar you earn. So every 30 cents of 1 ringgit of revenue goes on your labor costs. Nurses particularly. And of course, we now have a minimum wage. Yeah. So policies have ticked up. Ministry of Health actually dictates the staffing ratio. Yeah. Intensive care, you must have 1:1. And 1:1 means 1 registered nurse to 1 patient. Yeah. On the wards, you need 1 nurse to 5 patients. But if you're a surgical ward, there's a proportion, just not a state-registered nurse, but a state-registered nurse with a post-basic certificate in surgery. So we send the SRNs to have this extra training, and of course you have to pay more. So these are for patient safety. So we know why the Ministry of Health is dictating that, but it adds to costs. Then of course you've got the hardware, the buildings, the maintenance. I mean, you don't see Pantai Hospital with a junk of equipment sitting in the balcony, right? You don't. And then you've got the middleware, it's medical supplies, medical equipment is all imported. Pfizer, yeah, GSK, Roche, everything is imported. Very little is made in Malaysia or used in, from local pharmaceuticals. The other thing is, so last month, my auntie texted me urgently. She says, I need to ask you for a second opinion. I'm a Kopi O licensed by now. I haven't practiced for so long, but never mind. What was the question? My 2-year-old granddaughter has got flu, and the doctor wants to put her on antiviral medication for flu. So I said, oh, I didn't know that you could give such a young child an antiviral drug. So anyway, go and ask my pediatrician. She says, yes, after 6 weeks or 6 months, I think, you can give an antiviral medication for flu. But is the child really sick? You know, so it went back and forth. So the child is, her sister, older sister has had flu, her mother's had flu, they've all recovered. This one has just got the symptoms. The question is, do we really want to jump down that road? You know, antivirals are expensive and have a lot of side effects. And as I said before, do you want to have the full thing, said the cardiac case, pat you and say, sorry, just give you some pethidine and go home and rest? Or do you want to go the full swing into a cardiac lab and get everything done? Unfortunately, Malaysians, we are not the world's healthiest, and we are aging. So by 2050, we really will be aging. So great economy, but less healthy. We've probably got one of the single highest incidences of diabetes, type 2 diabetes, in all of Asia. I think only India is worse than us. And we're more demanding of our rights. So I've got a right to go and see a specialist. You've got a urinary tract infection, go straight to the urologist or the physician. Whereas you could go to KKM, be given the same drugs and pay 5 ringgit. Go and see a urologist and pay a lot more. So there are issues, you know. Next question is, are our healthcare prices reasonable? Actually, we don't know. We say that it's a very expensive bill in the private hospital, but we do not have a comparator. So again, a few years ago, we tried to compare an appendectomy in Ipoh General Hospital, UMMC, one private hospital, HKL. We got wildly different numbers because we couldn't decide what are the elements that you use. Because the Ministry of Health doesn't have to pay rent, it doesn't own its hospital. So how do you factor that in? The maintenance costs, the Ministry of Health outsources, they don't know. They only have the salary costs, right? So there was a lot of work, and then nothing happened, which we now need to redo, because is 20,000 for an appendectomy, if you really look at how much it costs to do that same thing in Hospital KL, would it be 20,000? Would it be 5,000? We don't know. And then we have this whole thing, wearing my civil service kind of hat. Should we make profit from healthcare? Should we make profit? So Kazana, I think Sue, we were at Kazana Megatrends Forum, and one of our, I think it was EPF, I think, he said, I love private healthcare. The return on equity is wonderful. And it's not a cyclical thing, it goes through. He said it more than once, huh? I was like, oh, yo. Should medical providers be profitable? And then the question is, how much profit? How much profit is? So if you look at Penang Adventist, which is semi-charitable, their bottom lines are only about 2%. Really net margins, 2%. In the early years, Sunway was 2%, and we gradually went up to 6 to 7%. Is that enough? But if you're owned by private equity, if you're listed, for instance, that's not enough, right? You won't be a stock market darling. So now every day if you look at the edge, right, you look at KPJ stock price, and you look at IHH stock price, and who holds and who buys, you see the difference. And one of the things also is that it's been quite quiet now, but a whole bunch of facilities are now swept through from TPG into Hong Leong, right? And there was nothing. I was like, isn't the competition guys, aren't they going to come and say, hey, what's happened? It's just happened. So we are becoming a little bit American when your private equity is coming in and nobody is talking about it, nobody is debating it. Yeah. So we're saying if we look at a fair, say, social insurance, which we had looked at several years ago during, just as Tan Sri Ismail American retired, I can't remember how many years, we did look almost to say, okay, there should be a central funding body, and then no private, no public. One tier of hospitals, and then DRGs. So the DRGs, and what is a basket of services that you are entitled to. So if I were 30 years old or younger, and I'm about to have my first child or my second child, what would I be entitled to from the social insurance? Antenatal care. How many visits to obstetrician? And your pastor is an obstetrician or was an practicing obstetrician. How many visits? How many scans am I entitled to? What medicines should I have? And that might be your minimal basket. But if I'm 35 and I'm hoping to be pregnant, but I'm having problems, does the social insurance pay for me to have IVF? And then your costs escalate. But I'm saying it's my right. I'm 35. So should I have a basic basket and then I top up if I can? Yeah? So, quick case studies. The costs of care. So, the one on the left, lung cancer, which unfortunately is getting more common, especially in Asian women. Don't know why. So at preliminary diagnosis, it's an expensive thing to do. You have your chest X-ray, CT scan, the bronchoscopy, do a biopsy, send it off for pathology, and then you might do a PET CT to see whether it's spread to the rest of the body. If it hasn't spread, you get in a thoracic surgeon, and the first thing you do is you take away that lump. If the pathology comes back and shows a genetic mutation, you might be treated with targeted therapy. Osimertinib is 8,000 ringgit per month. Is that my right under the social insurance? And then after that, I have to follow up with blood tests, CT scan, PET CT, every 3 months for life. Okay? So you can see that's a very expensive thing. On the right, cost of care of the old. This is actually a friend's mother. She's in her 90s. That's a pressure sore on her heel, on the heel of the leg, and that pressure sore actually did start. It actually ulcerated and started to bleed. She's got dementia. She can't eat, so she's being fed through a nasogastric tube. She's got full-time care at the moment, but if she had to go into a nursing home, minimum charge is 5,000 in a good care home. She's stayed in a hospital for urine tract infection and pneumonia, and the bill for 1 month's stay was 76,000, of which a big bulk was for medicines. And then because she's in her 90s, it's all paid out of pocket. Yeah. So again, when we look at social insurance, do we ration people and say, you're too old, go home and die? You know, if you want the active treatment, you pay. Yeah. So I leave you with this thought because, as I said, okay, just to say, with the last minute, a lot of big hoo-ha about why is my insurance so high, and the diagnostic-related groups, right? So at the moment, it's fee for service. So this patient, this 90-something-year-old patient, went in just for treatment of pneumonia and came out actually with this pressure sore, as well as a huge sore on her leg, yeah, which was not properly picked up. If you had a DRG or you have a framework in place, actually, you can go back to the hospital and say, it's your fault that my mother's developed these because she came in only for chest infection, but she's come home with these complications, so I don't pay for that. I only pay for the chest infection, the chest X-ray, antibiotics. Yeah. So a DRG, and this is where the doctors in the room, last time already don't talk just because of one referral form, right? DRG would be for the doctors all to agree. How do you treat a 94-year-old with a chest infection? What would you do? Which tests? How would you manage what drugs? And would you give her nasogastric tube feeding or what? And then combine it all together and say, this is what we will do, and this is therefore how much we will pay the hospital and the doctor for doing it. Okay. So I leave you with that. Sorry, it's a bit of a horrible thing, but you've just eaten dinner as well.
Thank you very much, Dr. Chong. Can I invite you to take a seat so we can have a Q&A session? Thank you very much, Dr. Chong. It was a very, very informative session, and we have learned so much. Malaysia actually practice a dual healthcare system. on one side, we have our public healthcare, which is heavily subsidized by the government through tax revenue. And on the other side, we have our private healthcare, which is actually fee-based. Now, you have shared medical costs has risen, and it's really the hot topic in town, right? And especially with medical inflation and advanced medical procedures, as you have shared, and including the rise, the prevalence of non-communicable diseases too, right? So would you be able to give us, as Malaysians, any advice for us? What strategies do we take to basically handle our expenses, our healthcare expenses effectively?
I was actually looking at this also in terms of your outreach ministry and what you do. Some years ago, when I was in Sunway, we teamed up with Monash Medical School, and they did some research in Kampong Medan, which is just next to Sunway, right? To look at what those households do in terms of their access to healthcare. And you realize that on paper, they do have access to healthcare, but then the closest clinic kesihatan is like 2 buses away. You go onto the NPE and then you turn right into Kampong Datuk Harun, or you go to HKL. And what the Monash team found is that both husband and wife would both be working in order to earn enough, right? And they didn't have the time to they weren't able to really take a whole day off to get to HKL or OKM. So what happened was that they would allow themselves to run out of drugs. Yeah, and then they would depend, and actually some churches would do some outreach and some hospitals would do some outreach and bring medications. So they would wait. So unfortunately, this is what, with our non-communicable diseases, so Malaysia is still suffering from communicable diseases, our dengue and a bit of malaria, for instance, TB, as well as diseases of the first world, so your diabetes, obesity, hypertension, and these tend not to give you any symptoms. So really, from our personal control of our health is to go and get your health screening done, right? And then if you go back to what the WHO said, universal healthcare grounded on primary care. It is so cheap to go to KKM and Klinik Kesihatan. It's not so expensive to go to a GP, but you need to do it. You really need to do it to keep an eye on your health level, and then it's about lifestyle change, right? Smoking, even vaping now is considered even more dangerous than smoking, yeah, for a variety of reasons. So it's really to take charge of your health, yeah, without blackballing all doctors and all specialists. You also want to be sure at the other end, when you really do need to have surgery or something, it's very un-Christian to say this, but you don't trust everything that a doctor tells you. Do your research. Do I really need to have a robotic surgery on my knee? Or can just computer-aided surgery do? Because the price difference is huge. You can do computer-aided surgery, actually, at my dear friend's orthopedic center for 35,000. You can go somewhere else and do a robotic surgery for 65,000. And that's what's causing your insurance premium to spike. So, and one of the things that's also causing our insurance to go up is you're being admitted for little things. So the flu was the single largest claim in 2023, 2024. Flu in hospital. what happened to Panadol and honey and lemon? You know,
Lemon and honey,
lemon,
doctor.
honey, yeah. So, and the insurance are now losing money on insurance, on medical claims because of all that, right? Okay.
I'm glad to tell you that I've visited Clinic Kesehatan before, and I just paid 5 ringgit. But I remember those days when we have cesarean procedure, it only cost about 2 to 3,000. And now it has tripled to about 15,000 more, depending on how complicated it is, right? And to my understanding, doctor fees are actually regulated under the Private Healthcare Facilities and Services Act. But then, however, having said that, hospital charges are not regulated. I remember, receiving a bill and I was like looking at it and it was like itemized. Oh, you have used this tissue, you have used this, and it came up to quite an exorbitant fee based on hospital charges alone. So, do you think that hospital charges should be regulated similar to doctors' professional fees? What do you think, Dr. Chong?
Actually, if you look at what our neighbor Singapore has done, all procedures, everything is listed right in websites. You can actually compare across hospitals. The issue really now is to find a bunch of economists and finance people who can work with the individual hospitals, and for the individual hospitals to be really truthful about how much the cost of care is. And so, wearing my AIA hat, what we did was, you use AI tools and you scan all the bills, and you can tell from every single hospital how much they're charging for every single thing, right? And compare. And you realize that hospitals do not have a central procurement. Yeah. So one hospital may buy gloves for 10 ringgit a box, and another hospital buys it for 12 ringgit, and then they just happily pass on the cost. So to actually understand how much it costs, you need your time and motion studies, you need your cost of purchase of the CT scan, your cost of maintenance, drill it all down and calculate it. No one has had the, so we still only know what the individual hospitals are doing, but it would be really good to know what UMMC is doing and what Ministry of Health is doing. Yeah.
I think the public and private sector should collaborate together in that sense, right? Like, for instance, you mentioned that IJN is still standing alone and not working with the private sector nor the other hospitals. There's so much that we can look into. But in your opinion, I mean, you've been in this medical sector for decades and you have such vast experience. What are the key policy changes that you would like to see nationwide, on the national front, that we could have a more sustainable and equitable healthcare in that sense? What do you think? Any, key policy changes that you would like to see made in Malaysia?
I think it still goes back to talking to each other. We make a lot of noise, but at the end of the day, we don't sit down and really get things off the ground. So that white paper on healthcare reform, I was supposed to have been put on a technical working committee to look at some of the areas, and it's gone totally silent. So we don't know what's happened. Bank Negara has been jumping up and down, but does not seem to have been able to engage, not as far as I can see, not been able to engage with Ministry of Health, Ministry of Education. Yeah. So I just do want our ministries to work together, but for somebody to really take the lead. And at the moment, I don't see someone taking the lead.
Unfortunately, there's still a lot of noise in the market.
Yeah.
But there's still a lot of indecisions between the bodies. Yeah, I'd just like to open to the floor. Any questions from the floor? Any burning questions for Dr. Chong? Anyone? Please, introduce yourself and pose a question. Thank you.
Hi, my name is Rajan, and there are a couple of things you talked about that really piqued my interest. I got back from the UK in '89, and so student, little bit of work, and then I came back. And as far as I was concerned, the NHS was absolutely wonderful. Everything I needed done was covered by the NHS, and it worked very, very well, which is incredibly different compared to the NHS, which is failing today. It's an absolute mess. So I just want to leave you with that reality, that truth. And I want to see whether you can actually tie in what you said about the layering on of private equity type, 20% internal rate of return goals, etc. And you said that, I think within the context of Subang Jaya Medical, SJMC, you're saying that we're becoming more American. And I think the US is the only developed nation that actually has a reducing longevity rate, as in lifespans are dropping. So America's totally messed up. Part of it, I imagine, maybe because a lot of the cutting edge drug research is being done there, and ultimately someone has to pay for it. But the way they're structured, the first line of defense is the Americans themselves. So we have a problem of the Americanization of the global healthcare ecosystem. We've got a situation where the UK NHS is falling apart. I would very much like your insights as to what we can do to build a barrier against the worst of the Americanization elements, why you think the UK NHS is in such bad shape, and from a very practical perspective, what you think Malaysia can do to make sure that things get better and not worse. So if that's not too much of a compound question, over to you.
You're right. The NHS has also been underinvested over the years. They've restructured. They've delegated budgets to the community and the GPs. They pulled the GPs into trusts, then they dissolved that and all that. So they've been through a very rocky path, and lost their way. Lost their way. I really don't want us to go down that road. So if we do go into a social insurance, and I'm not saying that social insurance is the be-all and end-all. I think when we looked at it, Taiwan was already suffering, quite a lot of deficit there. And I think Korea is also having issues. I think one of the things is that who pays for that social insurance, right? So the NHS spends about just under 9% of GDP. There used to be a health tax, but I don't see that actually listed out. The question is, when we went into GST at that time, we did consider carving out a percentage for healthcare. Then how much more do you pay? I think Australia, you pay 2% of your income into your health tax. I'm not sure that we can afford it on an individual basis. If you think about our demographics, our average or median income. So it will be difficult to get there. The Americanization of this fee for service, and there's no penalties for poor medicine and poor service. The insurers just have to buckle up and pay, even though that 76,000, if it had been a 50-year-old, they would have had to pay it. There's no recourse. So that's the thing we need. So on the one side, if we say we don't want to be NHS and have all the mess they're in, if we do want to structure it, there have to be penalties. At the moment, there are no penalties, unless someone sues the hospital or sues the doctor. There are no penalties. You get away with doing anything and everything you want. Yeah. So who takes leadership here is also my question. Is it really in the Ministry of Health? Or is it going to be another, maybe a more an integrated body that's got the financial institutions, the Bank Negara type thing, Ministry of Health, your research entities and your education entities, and then your major players, your pharmaceuticals are not part of the discussion at all. Your medical equipment suppliers are not part of it. So there's no consultative body that looks at it, and you don't have the patient advocacy. You don't have the patients that come up.
That's right. Thank you for your question. Moving forward, looking at all the scenarios and everything, who do you think should be the person who should be primarily responsible for these healthcare fees? I mean, we have looked at the social model, and we can also learn from Singapore with regards to MediSaved. But moving forward, should the government step in with different kind of channels like income tax, health funds, or should they, how do the other corporations come in? How do insurance companies work together? Or maybe EPF, I don't know. What do you think, Dr. Chong?
Yeah. I was going to say, so EPF has now expanded the number of diseases for which you can use your account to, right? Say renal dialysis or end-stage renal failure, etc. But the reality of it, the people in this room may have a healthy account too, but you are the minority. So, yeah. There isn't. So if you're thinking about out of pocket, we're already paying a lot of out of pocket expenses for healthcare. Do you need a charitable foundation to come in and help you look? Your private equity is not going to come in and help because they won't get the 20 times return, right? And I think this goes back to that economic transformation program when we said we needed to be a high-income nation because at the moment we can't afford it. And unfortunately, I think we will end up similar to the NHS, where we just trudge along, getting worse and worse and worse, until and unless the whole nation climbs up, and then you've got more money to spend on healthcare. So it's a bit dismal, really, isn't it? Yeah.
Truly, there's a lot of things to be done and a lot of reforms to be looked into. And really hope that the government and even the public-private sector should pull together and look into this issue, right? Yeah, because medical cost is a real issue and a hot topic for the longest time that we could remember. Anyway, thank you so much, Dr. Chong, for sharing with us. Can we just give her a big hand? Because we have learned so much from her and such a privilege to have her here. Thank you so much, Dr. Chong. Yeah. Thank you so much. Would you like to have a seat and join us for the rest of the session?